Okay, let's dive straight in. Ever felt that that pressure needing to really nail down a complex medical topic like right now?
Yeah, happens all the time. Maybe you're prepping for an exam or, a patient case just throws you a curveball.
Exactly. Well, today we're going to laser focus on one of those, Tumour Lysis Syndrome,
Hmm.
TLS. Think of this as your rapid fire mission briefing. Gets you completely up to speed.
Right. We've got a great set of revision notes here, and the goal is, well, to pull out the absolute core knowledge you need
We want you to really get TLS, not just understand it, but have those key details locked in.
for when it really matters. Yeah.
So consider this your express route. We'll hit the definition, what causes it, the etiology, who's most at risk, the chain reaction in the body, pathophysiology,
What else might look like differentials?
how common it is, the signs and symptoms, the investigations you need, management, prognosis, and of course the complications.
We'll try to throw in some memory tips too, help it all stick.
Ready for this deep dive then?
Absolutely. Let's start right at the beginning. What exactly is Tumour Lysis Syndrome?
Okay. So fundamentally, TLS is, well, it's a potentially life-threatening situation. It happens because cancer cells break down really rapidly, usually during treatment.
And when those cells burst, all their insides spill out into the bloodstream.
Right. And that flood of intracellular stuff, it triggers a whole cascade of metabolic problems, and that can damage organs.
And the key things spilling out, the metabolic hallmarks you need to know, are hyperuricemia,
High uric acid,
hyperkalemia,
high potassium,
hyperphosphatemia,
high phosphate,
and hypocalcemia.
low calcium. Got it. Those four are crucial.
Definitely. Remember those four, and you're well on your way.
And you typically see this with blood cancers, right? The ones with really rapid cell growth.
Exactly. Hematological malignancies. Think aggressive leukemias, where cells are just multiplying like crazy. And it usually pops up pretty soon after starting chemo or radiation,
How soon are we talking?
often within, say, 1 to 5 days. It can be quite quick.
Okay. And isn't there a formal scoring system for this?
Ah, yes, the Cairo Bishop scoring system. From 2004, it basically gives us two main categories to think about.
Which are?
First, there's laboratory TLS.
Mm.
That's purely based on the blood results, showing those abnormalities we just listed: high uric acid, potassium, phosphate, and the low calcium.
So just the numbers on the lab report?
Exactly. Then you have clinical TLS. That's more serious.
How so?
It's when you have those lab abnormalities, the laboratory TLS, plus the patient starts showing actual clinical signs because of it. Things like kidney injury, you'd see increased creatinine, or cardiac arrhythmia, or even a seizure.
Ah, so the lab results are actually causing tangible problems.
Precisely. It tells you the metabolic chaos is having real serious effects on the body.
Okay, definition covered. Now, the why. What actually kicks off this massive cell breakdown? The etiology.
It really boils down to that massive sudden release of all the intracellular stuff when a huge number of cancer cells get destroyed almost simultaneously.
Like a dam break.
Sort of, yeah. Think about chemotherapy or radiation doing its job really effectively on a large tumor. All those dying cells' lyse, they burst open. Even steroids, the notes mention, can sometimes contribute.
And it's those aggressive blood cancers again, right? High tumor burden, lots of cells, and high growth fraction, they're dividing fast.
Absolutely.
Yeah.
More cells means more stuff released when they break down. And yeah, certain chemo drugs are known to be higher risk, especially in acute leukemias.
Okay, so we know what it is, what causes it, who should we be most worried about, what are those key risk factors?
Good question. We can group them. First, the tumor itself. Like you said, high burden, high growth rate. That's a big one.
Makes sense. More fuel for the fire, so to speak.
Exactly. Then there's the treatment, really potent chemo or radiation. The more effective the treatment at killing cells quickly,
Mm.
the higher the TLS risk.
And patient factors.
Oh, definitely. Pre-existing kidney problems are a major red flag. The kidneys are working overtime trying to clear this stuff, so if they're already struggling, right, dehydration too. Makes it harder for the kidney. So keeping patients well hydrated is really important.
Always key. Any other patient risks?
Yeah, if someone already has high uric acid levels, for example, that predisposes them. Age can play a role. Children are sometimes more vulnerable. And again, the type of cancers, huge acute leukemias, Burkitt lymphoma, those are top of the list for risk.
Got it. So high-risk tumor, potent treatment, vulnerable patient. That's the setup. Now let's walk through the actual process, the pathophysiology. What's happening step by step inside the body?
Okay, so cells of lyse, they dump nucleic acids, potassium, phosphate, uric acid into the blood.
And the body just gets overwhelmed,
Completely. The kidneys, the normal excretion pathways, they just can't handle that sudden massive load.
leading to those four horsemen: hyperuricemia, hyperkalemia, hyperphosphatemia, hypocalcemia. Let's break down how each causes trouble.
Right. Hyperuricemia, the high uric acid, it can actually crystallize in the kidney tubules, like forming little stones.
Which blocks things up.
Exactly. Blocks the tubules, causes acute kidney injury. Then hyperphosphatemia, high phosphate. It likes to bind with calcium.
Ah, and that causes the low calcium, the hypocalcemia.
Partly, yes. But it also forms calcium phosphate complexes, like a sludge, that can deposit in tissues, including the kidneys again, making kidney problems worse.
Nasty stuff. And the potassium,
Right.
hypertolemia,
That's a big worry for the heart. High potassium messes with the heart's electrical signals,
leading to arrhythmias.
potentially life-threatening ones, yes.
Okay.
And finally, all this metabolic mess can lead to metabolic acidosis, throwing the body's pH balance off.
Ugh.
Put it all together, and if you don't intervene, you're looking at serious organ dysfunction.
It really sounds like a dangerous domino effect. So if a patient presents like this after cancer treatment, how do we make sure it is TLS and not something else? What are the differentials?
Very important point. You absolutely have to consider other things. Could it be another cause of acute kidney injury? Maybe dehydration or a drug that's toxic to the kidneys, or even a urinary tract obstruction?
Okay.
Other causes of metabolic problems. Could it be sepsis, an endocrine issue? Adrenal insufficiency can mess with electrolytes.
Right. And the electrolyte issues themselves or the acidosis, could they be from something else entirely?
For sure. Certain poisonings, severe dehydration again. So you need the whole picture, the history, exactly what treatment they had, the pattern of the lab results, maybe imaging. You have to rule out the mimics.
Makes sense. Requires careful detective work. Now, how common is this? What's the epidemiology look like, say, in the UK?
Well, it varies quite a bit. Depends heavily on the specific cancer and the treatment used. But as we keep saying, you see it most often with those aggressive blood cancers, acute leukemias, high-grade lymphomas. High cell turnover is the key.
But the notes mention things are improving.
Yes, that's the good news. The incidence seems to be trending downwards. And that's likely because we're much better now at identifying high-risk patients beforehand and using preventative strategies. Better supportive care overall.
That's really encouraging. Okay, so if TLS is happening, what are the clinical clues? What signs and symptoms should make you sit up and take notice?
It all flows from those metabolic problems. So you're looking for signs related to the high uric acid, high potassium, high phosphate, low calcium.
And how might those actually show up in the patient?
They might feel generally unwell, fatigue, weakness, muscle cramps, maybe nausea, vomiting. Then, kidney-wise, you might notice they're not passing much urine oliguria or maybe none at all aninuria.
And the more severe signs?
That's when you hit clinical TLS. Things like cardiac arrhythmias. They might feel palpitations or worse, seizures. And the clear signs of acute kidney injury.
Okay, those are serious red flags. How do we confirm the diagnosis? What investigations are key?
Lab tests are the bedrock. You need to measure those electrolytes repeatedly. Uric acid, potassium, phosphate, calcium. See the characteristic changes.
And kidney function tests too, presumably.
Oh, absolutely. Creatinine, urea, monitoring those closely is vital. Often you need serial measurements, checking them frequently to track the trend and confirm it's TLS.
Does imaging help?
It can do. Ultrasound or CT might be useful to check the kidneys, look for obstruction, see if there's any other organ involvement contributing.
And what about ongoing monitoring once you suspect it?
Constant vigilance. Strict fluid balance monitoring. How much urine are they actually making? Continuous ECG monitoring is crucial because of the arrhythmia risk from hyperkalemia. Regular checks of kidney function, maybe GFR calculation. Some places also monitor things like LDH, urate, lactate. They can sometimes give you an early warning or track severity.
Right, monitoring is key. Okay, we know how to spot it. Let's talk management. What's the approach?
The absolute #1 principle, stressed in the notes, is prevention and risk assessment before chemotherapy even starts.
Sure.
For anyone with a hematological malignancy, identify the risk level first.
And the strategy depends on that risk level.
Exactly. Low-risk patients, you just monitor them closely, fluids, electrolytes. Intermediate risk. They usually get prophylactic oral allopurinol for about a week to block uric acid production, plus you push fluids.
And you mentioned urinary alkalinization is out.
Yeah, the guidelines now explicitly say it's no longer recommended. Used to be done, but not anymore.
Okay. What about the high-risk group?
For high-risk patients, the go-to prophylaxis is usually a single fixed dose of IV resburicase. That's an enzyme that breaks down uric acid really fast, plus aggressive IV hydration.
And no allopurinol for them.
Generally, no. It's usually unnecessary with resburicase, and there's even a suggestion it might slightly reduce resburicase effectiveness. So resburicase and fluids for high risk.
That's a really important distinction. Okay, so that's prevention. But what if TLS actually happens? How do you manage established TLS?
It becomes a multidisciplinary effort. You need hematology, nephrology, maybe intensive care involved. If they have clinical signs of TLS, they often need moving to ICU or HDU for close monitoring and support.
And the core treatments?
Aggressive 4V fluids, but crucially, fluids without potassium. You don't want to add fuel to the fire.
Yeah.
Daily infusions of resburicase are usually continued to get that uric acid down fast.
What about the low calcium?
You only treat symptomatic hypocalcaemia. So, if the low calcium is causing symptoms like tetany, you give IV calcium gluconate. But you don't give it routinely just for the number, because that can increase the risk of those calcium phosphate deposits.
Okay. And monitoring continues?
Absolutely, continuous cardiac monitoring. And if the kidneys really fail or the electrolytes are dangerously out of control despite treatment, dialysis might be needed. Usually hemodialysis, not peritoneal dialysis.
And again, no urine alkalinization.
Correct. Not recommended.
So intense support, fix the electrolytes, protect the organs. What's the likely outcome? The prognosis?
It really varies. Depends on the underlying cancer, how severe the TLS metabolic chaos got, and crucially, how quickly treatment started. Early recognition, aggressive management, that's key for a better outcome.
And if you catch it early?
With prompt, good supportive care, you often see things improve significantly. The metabolic numbers get better, organ function recovers.
But severe cases?
Severe cases, especially if there's already significant organ damage by the time it's picked up, they carry a much higher risk of, well, morbidity and mortality.
Yeah.
It can be very serious.
Which leads us to the potential complications if it's missed or poorly managed.
Yeah, the downstream effects can be severe. Acute kidney injury, sometimes needing long-term dialysis. Those dangerous electrolyte imbalances, the hyperkalemia causing fatal arrhythmias, hyperphosphatemia, hypocalcemia causing seizures, metabolic acidosis, and in the worst case, multi-organ failure.
Truly life-threatening possibilities.
Definitely. Which just hammers home why early recognition and proper management are so critical. And of course, the patient's overall prognosis is still heavily influenced by their underlying cancer, too.
Okay, let's try that recap mnemonic again for the key metabolic issues. Maybe think PUKH, phosphate up, uric acid up, potassium up, hypocalcemia, calcium down.
PUKH, yeah, phosphate up, uric acid up, potassium high.
And hypocalcemia.
And hypocalcemia. That works. It's good shorthand. But the real takeaway message is, know the risk factors, know the signs, and know the basics of prevention and management.
Absolutely. This stuff is vital if you're looking after patients with hematological cancers. Acting fast makes a huge difference.
It really is.
And if you want to dive deeper into TLS or revise other key topics, definitely check out pastthemsra.com.
And freemsra.com, too. Both are excellent resources for studying and revision. Really valuable.
Definitely worth your time.
Absolutely. Keep learning, keep asking questions, and keep putting that knowledge to work for your patients. That's what it's all about.